to you.
All right. Well, thank you very much for that introduction, and thanks everyone for joining us today on a Tuesday afternoon. And so I think we'll just launch into it. Who we are and why we're here. And so Max and I will chat with you guys. I'll probably spend the first 10, 15 minutes talking about what we built and where we're at, and then Max will take over and go from there. So, this is TGH. Those of you who've never been there, we're a big transplant cancer hospital, major oncology and surgical hospital. So those are probably the three areas. We do all things cancer, we do all things cardiac and transplant. And so this was a program that was started in 2014 with a pilot grant from the Ministry of Health. Obviously, it was a pain program, but I know we're talking to the Opioid Stewardship group, and I often say I speak to the group and the audience and deliver the message that they typically want to hear. And so, although I was building a pain program, clearly the opioid stewardship piece was a big point at that point in time, and one of the asks from the ministry was to figure out how we can help, deal with some of the opioid and post-op opioid prescribing practices that we thought at the time was a relatively major player in terms of people persisting on their opioids after surgery. I just put this up here because this is kind of where things landed. It was at the heart of the opioid crisis. Hoskins was still our premier. And with some of our patients and some of the work we were doing, we were really highlighted as being part of the potential solution, and they created these first emergency task force opioid committees, which we got to be a part of as things rolled forward. And so this is kind of one of the key, I would say, papers that pointed out what we're trying to do and why a targeted approach is better than perhaps an approach for all. And so this was a paper by Kareem Latta. He was a colleague of ours over at the General. He's moved on to St. Mike's. And it was a simple question. How many patients actually land in a scenario where they have a post-operative opioid overdose 90 days after surgery? And this is a pretty big American database. And you can see that anybody who walks into the hospital on less than 50 milligrams of opioids typically do quite well. And this is really a non-factor, if not a negligible issue whatsoever. But as soon as you look at the individuals above 50 milligrams and certainly above 100 milligrams of milliequivalents of morphine daily that walk into the hospital pre-surgery, they're the ones at higher risk. And they're typically the ones that walk out and double and triple the dose at times as we move down the road. And so really setting the scene to say, we all want to change the system for everyone, but really and truly, we know that 85% of people that come through our operating rooms do well. And who are the people we should start to really be concerned about based on current practices? And that became pretty clear. So from a transitional pain service perspective, this was a service that started kind of in the acute post-op setting primarily. When we rolled it out, it was an interplay between the acute pain nurse practitioners and the anesthesiologists, and then we hired in psychologists and admins. A patient database coordinator was pretty big for us as well. And so those were what we funded in the initial ask from the ministry. It was a 2-year grant, went on to be a 3-year grant because we were able to juggle some money and actually put the money into resources that were needed and expanded. And based on the data that we captured over the next 3 years, we were in an opportunity to land permanent funding for the program based on, publishing and some of the things that we were doing. Now we obviously have been entrenched in the institution, and post-operatively surgeons are referring to us in that early post-op period, whereas before they really didn't have an understanding of what we were doing. And even preoperatively now, in particular, our transplant patients are some of the populations that get sent to us very early on. We know there's a lot of data out there now in the last couple of years to speak to outcomes post-transplant medicine if you have a pain problem and are on an opioid medication preoperatively. So, this whole transitional pain concept, I often get people ask, why did you call it that? And there are so many transitions, obviously, in medicine. We are a pain program. Our real, reason that we created this was to look at that transition between acute and chronic pain. We know there's the transition adolescent to adult, hospital to community. We've become a program, and this is what Max is probably going to focus on with you, talking about, how do we help opioid wean? How do we transition patients to buprenorphine naloxone? And it's interesting. I'm going to be at a meeting after this one talking about appropriate prescribing in general and deprescribing and some of these things. And certainly that's where we have landed as a clinic over time, helping people get off of some of these barnacles that they've been put on. And this is something that we've published and been funded for by the SUAP program to put a how-to guide. One of the things they said to us is, well, you're publishing all of these things, but what are you actually doing in the service, and how would other people, put together a service like this so that they can have a similar functioning program in their institution? And so that's the link at the bottom if any of you want to pull this down. And it really speaks to using the resources that you have at your disposal and building upon those. And so there's no one cookie cutter model. It's certainly a model that can be used based on what your resources are. I was speaking to the University of Alabama Birmingham actually this morning, and they have a massive health center, and they do want to build these things in, but they haven't put together the specific pieces that will be needed for their service. So they want to talk about what some of those might be. Just a story about those patients that you're seeing on the wards. He was a pretty big chef in the province of Ontario. His best friend was a chief of police, believe it or not, at the time he was in hospital. And we went and saw what was going on. He had an umbilical hernia. He was using his PCA, and we asked his wife simply, what's going on? Something seems off here. She broke down in tears, saying, "My husband, is spending $200-300 on illicit Percocets, and we need some help." It's been since transitioned to buprenorphine and doing quite well. Actually, we just saw him in clinic. We probably see him once or twice a year. We're trying to transition some of these folks out. Some of the things that you need to be aware of is, just the appetite for the primary care docs to sometimes take back some of these patients, et cetera. And sometimes the patients don't want to go. And so, those are things you can work through over the years. And we published this with folks in Calgary, just talking about home induction of buprenorphine and how we go about doing that. It's a 48-hour induction method. I almost bring nobody into the clinic anymore to convert them off of their opioids onto buprenorphine, naloxone products, and Sublocade, and all of these other products that are now being used quite often when someone's co-diagnosed with an opioid use disorder issue on top of a pain problem. In the background, as much as this has been really something that's been taken up across Canada and North America and around the world, there's still the naysayers that say, well, where's the evidence? Where's the randomized controlled trials? Why are we doing this? What's the cost efficacy and cost efficiency? The Americans, I think, out of Michigan did a business case on the transitional pain service in the American system, which is very different to ours. And they're saying that it's at least cost neutral and certainly spares the institutional beds in terms of having a patient for some of these difficult patients to land, et cetera. So look out for some of those articles that'll be coming out. I'm going to finish off with what we've just found and we're looking to publish in the near future, which is those patients in red. If you look at that across the continuum there, some of them are on their opioids pre-op. You can see the people that we take out of the institution are those that are 3x probably what the rest of the province is seeing. And what this graph pretty much represents is that the return to baseline is quite steeper from a TPS model, and this was just health administrative data that we're looking to. It's under a revision now at a RAPM, if I'm not mistaken, and we're going to hopefully, move into the next phase from administrative data into those RCT pieces. But I think we all know that any type of pain program is not sufficient with just your physician care, and you need your allied care, and you need the real triad. And so the physicians can prescribe, and we can put needles in places, and that's the easy part. The patient needs to take ownership and get the physical aspects and the rehabilitation aspects going, which we do have a physiotherapist in the program, but we have really built this program at the interplay between pain and mental health. And so I think this is where I'm going to turn it over to Max and have him kind of talk you through some of the parts of the programs that he has built, which really support the opioid weaning piece that I think a lot of you are interested in hearing. Over to you, Max. I think you're on mute, bud.
Yeah, I'll just I'll let you know next slide when we're moving along.
Sure.
So, great to be here. Thank you so much for having me. As they said, my name is Dr. Max Slepian. Please, everybody call me Max. And I'm the lead psychologist with the Transitional Pain Service. So I'm going to talk a little bit about what our role is. And so Hance introduced this idea of kind of this triad that's medicine, mind, and movement. But what is it that psychology does? And so we are asked within the Transitional Pain Service kind of very specific referral questions. And so who do we see? We see individuals that need non-pharmacological pain management, um, and also that need support with opioid weaning. And this goes hand in hand, right? And I think it's the idea that this is not, we're not offering these patients a replacement for medication, a replacement for the injections, a replacement for anything else. We're offering them something in addition, right? And that if they're able to uptake what's in addition to that, they might not need those other things. And with opioid weaning in particular, it's about understanding kind of where they are in their readiness to change. How do we move them along, and so that they're understanding more that these opioids generally, um, at high doses, are not doing for them what they want them to be doing,
Did you
right?
print any of those things?
And then what
Yeah.
something I'll speak to a little later specifically is support for buprenorphine and naloxone initiation. And so one of the things we've done, and there's very little in the literature on this, is that we've developed a protocol for kind of an integrated medicine and psychology approach to getting patients from their opioids onto buprenorphine, naloxone, or Suboxone. There are some practicalities inherent in psychology as part of a service like this. The biggest one is that we are time and labor intensive, right? So as a psychologist, I meet with patients on the first occasion 1 to 2 hours, the subsequent occasions half an hour to an hour each time, and an intervention takes maybe 6 sessions, right? And we don't reimburse for services in really any way at all for the hospital, so it's a challenge. And in that way, we're kind of a limited resource. So we see those patients for whom it's most needed. We identify this based on kind of our screening questionnaires, which we deliver to everyone. But also a lot of it is based on having really excellent physicians that know who's going to benefit from psychological support. And that's kind of a continuing conversation always between amongst the team, right? And with that, it's who do we not see? We don't see folks, if they have strong supports elsewhere. I might see a one-off and liaise with their mental health providers elsewhere. And we don't treat primary psychology or psychiatric disorders. It's just outside the scope of what we're able to do. We can't undertake long-term therapy with folks. All right, next slide, Hance. Just very briefly, 2 seconds, just stepping back and saying, why is psychology involved in this? And really it's because there's strong evidence for psychological factors as predictors of the development of severe acute pain and long-term developing chronic post-surgical pain. Next slide, Hans. And so you can see it here, both kind of at this is just a zoom in of that last crazy figure from a paper that came out almost 15 years ago now, I guess. And you can see the zoom in where in the preoperative area, we have these kind of well-identified factors: depression, state anxiety, really emotional distress, pain catastrophizing, poor quality of life, high pain, and then some protective factors as well, like robustness and optimism. And then in the acute period, those psychosocial factors come back, including social support, and then in the longer term as well, and kind of longer term sequelae from surgery and how those impact pain as well. Next one. And so these present themselves as treatment targets for psychology because they're predictors of both CPSP, chronic post-surgical pain, and opioid use. And so the biggest target is pain. Psychologists, there was a recent meta-analysis published in the journal Pain last year that there is evidence that psychological interventions can reduce pain at 3 months and 6 months after surgery. And that standalone psychological interventions, short and long, delivered before or after surgery. These can either target pain and pain coping directly, or psychological risk factors: depression, anxiety, catastrophizing kinesiophobia, fear of movement, and try to enhance protective factors such as self-efficacy and optimism. Next slide. And so what is the approach that we take on the psychology side at the TPS? And I think I want to highlight that we adopt something we call evidence-based practice, right? Where we are trying to use a patient-centered approach at all points. And there's really, I think, a strong understanding in this opioid weaning literature that when there isn't a patient-centered approach, the kind of forced weaning or attempting to force patients to transition to Suboxone is going to cause harm, right? And so this is a really critical part of any kind of any approach to opioid stewardship, I suppose. Um, and then from a intervention side, we base our interventions in acceptance and commitment therapy. Primarily, the thing that's on the right here, which is called the acceptance and commitment therapy matrix. And a big component of this, and this is very much uh, not the language perhaps an ACT practitioner would use, but is to shift focus away from the struggle with pain, which is where patients get caught on opioids and getting stuck in the cycle of pain and opioids, and shift them towards meaningful activities. Right. And so if we can get them to and help them find a place where they're able to accept that either this pain is chronic and that they can still continue to make movements towards finding treatments, and then they can focus on things that are meaningful to them. And with that, we have a pretty flexible integration. So I always incorporate pain neuroscience education, elements of dialectic behavior therapy, and particularly dialectic behavior therapy skills training, which I'll come back to at the end, clinical hypnosis, and then other mindfulness and behavioral approaches. And so I'm happy to speak to that a little more. And so our treatment approach is brief. The goal is kind of one or two points, right? Is can we shift a trajectory? So if we're seeing somebody immediately after surgery, can we deliver a brief intervention, deliver that intervention to as many people as possible, and shift a trajectory where they might continue to use opioids and otherwise wouldn't need them? And these are those folks that Hance was saying are leaving the hospital on 3 times the dose that they came in on, right? And can we do something as quickly as possible? The other places where there are critical points, like initiating Suboxone and moving them from an opioid to Suboxone, can we do a brief intervention around that time to kind of ease that process? We do primarily individual therapy. We do some group therapy, very time limited. Because our goal is brief, we're not going to do long-term groups. We base it on what's called the acceptance commitment therapy workshop model that was developed by a psychologist named Lillian Dindo and her colleagues, and has some really good evidence support. We also do provide inpatient consults and may visit patients on the ward, depending on the need. So we have some good evidence from kind of our clinical practice data collection, which I think Hance mentioned, is that we collect data for everything that we're doing. And we did have prospective RAB approval to collect data at every visit, and we were able to look at these outcomes and identify that in particular uptake of acceptance commitment therapy was associated with reduced opioid use, improvement in pain interference, and depressed mood, while patients were in the program. And that was comparing those who came to multiple visits with psychology versus those who either did one visit or no visits with psychology. And then we have evidence for TPS multidisciplinary care as a whole, right? So improvements in pain intensity and pain interference, pain catastrophizing, and that half of opioid naive patients and 1 in 4 opioid experienced patients were fully weaned at 6 months after joining the program. And I think we're going to have some new data coming out that I think is in prep for submission that's going to show some pretty excellent outcomes as well of patients coming back down to either pre-surgical levels or back down to zero for their opioids. We're also doing some other projects kind of looking at new avenues for intervention. One of those is that we've completed an RCT looking at pre and post-surgical clinical hypnosis. And so that was one 25-minute hypnosis session before surgery, one 25-minute on the ward after surgery, and it was associated with less opioids consumed across the first week after surgery. We have the Recoup trial, which Hance already mentioned, so I'm not going to go into that. And then we've also been working on kind of how do we make this service more accessible. And so I mentioned already that psychology is a bit of a shortfall for even our program, right? And so we are time intensive, and we're only able to see a portion of those that are coming through the transitional pain service. There are very few psychologists that specialize in this area of treatment. And so how can we make that more accessible? And so we're working on a project we call Advancing Online Psychology Tools for TPS, or Adopt TPS, that hopefully will be able to provide digital platforms that will be able to hopefully not replace psychologists, but provide additional support in places where psychology support or mental health support is limited, right? And so if we can replicate the psychology components of what we're doing, make it accessible, and have physicians or other providers be able to refer to these programs, maybe we can provide that same kind of support. All right, go ahead. And then I just want to take a moment to specifically describe this psychology protocol we've developed for buprenorphine naloxone or Suboxone. And so we're trying to have all patients that are planning a initiation or induction of Suboxone to meet with the psychologist. And we usually do approximately 2 sessions prior to the induction. So once they've worked with uh, the physicians and they kind of have an idea that this is something that they're really considering, right? We take a very patient-centered motivational interviewing approach, and we're really trying to hear to assess readiness to change and see if we can move them along that spectrum. Because like Hance said, this is really, it rests with the patients, right? And so if they're not engaged, if they're not motivated to undertake this kind of initiation, it's not going to work out, right? And so we can't necessarily we don't want to browbeat anyone into doing this, right? This is about helping them understand where and how this is going to be helpful, and if they can kind of create that motivation for themselves, right? And we can reinforce that. Um, we provide quite a bit more psychoeducation, partly because as psychologists, we have more time with patients when we're meeting with them on kind of what to expect, what are going to be the those symptoms of withdrawal that are going to come on as they're switching from an opioid to Suboxone. How long are some of those things expected to last? How intense? What is it like going to be like as our physician colleagues, call them every couple hours during the day, right? What is that going to be like for them? We might help answer questions from family members or other folks as well. And then a big component of what we do is coping planning. So we have, a 24 to 72-hour window where things are going to be pretty rough, right? That they might be adjusting. They're going to be getting their withdrawal scores taken by the physicians. They're going to be adjusting their Suboxone dose. And what can we do on a behavioral side? And we recommend for everyone distraction, lots of distraction, as immersive as we possibly can. We recommend uh, engaging in pleasant activities, right, as much as possible. We then use DBT skills, particularly what's called TIPS, or temperature intense exercise, paced breathing, and progressive muscle relaxation. So all things to kind of change body chemistry. Um, and those are kind of for more intense moments, they can do that. And then we offer them support with mindfulness and hypnosis as well. And so we have videos available online. We give them coaching on how to use those. We might practice those. And then I'll continue to meet with people after the initiation, and to check in to see if I can provide coping support, do a meditation with somebody, and kind of continue the motivational interviewing work to kind of reinforce why this is valuable to someone, right? And how this can move them through, and kind of what, and really focus on the benefit for quality of life that comes with this, as we've actually heard from many of our patients. And this is outlined a bit as part of a bigger case report that was just submitted as well, that looks at how we undertook one of these in a patient with quite a complex medical picture. All right. I think that's everything I had for today. So, any questions?
And I think before we just turn over to questions, I wanted to reiterate that I think I forgot to mention. So not everybody sees the psychologist. Unlike some of the chronic pain models where we have, 5, 6 people sit around a table, It's just not from an efficiency standpoint. It didn't seem to make a lot of sense in our model of care, so we never adopted that model. We are still somewhat of the gatekeepers that send the folks onto Max, and we do a good bit of obviously psychometrics on these patients in terms of all of those entities that you saw on that complex diagram there. So we know what their catastrophizing scores are, their HAD scores, their GAD-7 scores, all of these things are embedded in a mobile platform that we use, and we can log in and take a look at where these patients sit. So I just wanted to add that context.
Right, thank you both so much. It was a great presentation. I'm just going to stop the recording here.